We are live, ma.
Good morning, everyone. A warm welcome to the Facebook Live session. I am Dr. Pramodha, Clinical Head, Oasis Fertility at AJ Hospital, Kuntikana, Mangalore. This talk is mainly an introduction to infertility, especially it's aimed at educating the general public. What is the real cause of infertility? How can we overcome it? What are the various modalities available in fertility treatment? So, this is the topic that is all you want to know about infertility. Now, what is infertility? Infertility is defined as failure to achieve a successful pregnancy within 12 months or more, in spite of having regular unprotected intercourse. Now, approximately 85% of the couple who are trying for at least for a year will be able to achieve pregnancy, another 5 to 10% in the second year. So, total of around 10 to 15% of the couples might require fertility consultation. So, according to the WHO, that is World Health Organization, infertility can be primary or secondary. Primary infertility is one who has never conceived. Secondary infertility is they have conceived at least once. That is one successful conception. It would have been an abortion, it would have been an ectopic, etc. Now, coming to the demography, see, infertility is very important because it affects millions of people of reproductive age worldwide and has an impact on their families as well as communities. So, the estimate suggests between 48 million to 186 million people globally are affected by infertility. Now, what are the causes? So we have got causes in female reproductive system, causes in male reproductive system. So the female cause can be 30%, male can be 30%, and in both it can be again 30%, and 10% can be unexplained infertility. So in the female, just see, this is the female reproductive system. We have got the ovaries. Ovaries are nothing but here the sperm egg production will occur. So each one is born with a definite number of eggs, and the same eggs will be released in after puberty. So totally 400, around 400 eggs will ovulate in the entire reproductive lifespan of a female. So the problems can be in the ovaries. What can be the problems in the ovaries? Problems in the ovaries, it can be there will not be enough egg at all, or there might be enough eggs. It may not ovulate, which is called as anovulation. And anovulation, commonest cause of anovulation is PCOS, that is polycystic ovarian syndrome. I will come to these topics one by one as the time goes on. Okay, then from the ovaries, the eggs which are released, which is nothing but ovulation, the egg is picked up by the fimbria. Okay, these are the finger-like projections which are in close relationship with the ovary. So they pick up the egg which is released, and then it is moved on and enters the fallopian tube. So this is the fallopian tube. Okay, from the fallopian tube, it comes to the uterus. Yeah. From the fallopian tube, it comes to the uterus. So in the fallopian tube, what happens? There are a lot of things happening in the fallopian tube. As you see, the fallopian tube is not that simple. It has got different types of cells which nourishes the egg, and also it will propel, the ciliated cells are there which will propel the egg to the fallopian tube. And in the ampulla of the fallopian tube, I'm losing the cursor, sorry. So in the ampulla of the fallopian tube, what happens is when the egg meets the sperm, there will be fertilization. And this fertilization again it is nourished by the fluid in the fallopian tube, which is again secreted by the cells in the lining the fallopian tube. And these embryo around 5 to 7 days time span, it enters the uterine cavity, and at the same time, this is the endometrium, okay, of the uterus, and the endometrium has to be receptive when the fertilized ovum comes to the uterine cavity, and it gets buried into the uterine cavity or the endometrium. It gets buried within the endometrium, and then it goes on developing to a fetus. So the problem can be in the ovaries, it can be in the fallopian tube, it can be in the uterus. Uterus, there can be various anomalies of the uterus, and or it can be in endometrial defect. It can be a defective endometrium, or there can be some growth, like the commonest benign growth is the fibroids, which might impinge into the uterine cavity called a submucosal fibroid, or it can be within the myometrium. So, coming back to the causes, ovarian factors affecting 30 to 40% in form of anovulation, that is failure to ovulate. Then luteal phase defect. Luteal phase defect is whenever the eggs are, when the egg is ovulated, uh, the luteal phase, what happens is the corpus luteum, the whatever is left behind, it is called as corpus luteum, that will produce estrogen and progesterone, and that will support the endometrial growth. But if the endometrial growth is not supported because of defective corpus luteum, then the growing embryo will not be supported. The patient might have an implantation failure or an early abortion. Then there are certain toxins which can affect the ovaries. Like, mainly we have got the chemotherapy, and also the radiation, pelvic radiation can destroy the ovaries. Next, coming to tubal factors, as I've already told, this also will be affected in 30 to 40% of the females seeking infertility treatment. So, what are the causes which can lead to tubal factor infertility? We have got pelvic inflammatory disease. Pelvic inflammatory disease, how is it caused? Pelvic inflammatory disease is usually caused by the infection of the tubes. Infection of the tubes can be in the form of chlamydial infection, gonococcal infection, etc. Many of them, and also we have got chronic pelvic inflammatory disease, which is caused by tuberculosis. So some of the infection may go unnoticed. Patient may not give any history of any history suggestive of infection. So what are those? Especially the chlamydial infection and tubercular infection usually go unnoticed. But tubercular infection, chlamydial infection, and few of the acute inflammatory pelvic inflammatory disease, usually it is seen in sexually active ladies. But pelvic tuberculosis may be seen in childhood also. At the time of puberty, they are more prone to contact tuberculosis. So all this can either cause disruption in the tubes, the cilia and the delicate tubal architecture, or it can block the tubes. Next, we have got endometriosis, which is also affecting most of the ladies. Around 30% of the females who comes to the clinic, infertility clinic, will be diagnosed as endometriosis. So here, what happens is in endometriosis, what is the cause which is leading to tubal factor infertility, there can be adhesions, especially outside the tube. So when the adhesions are present outside the tube, they can change the tubal because of the adhesion, the tube can be blocked. And also post-operative adhesions due to any operations, especially the pelvic operations like myomectomy, then any ectopics, etc. These can lead to adhesions in the pelvis. Uterine factors. Uterine factors, we have got fibroids. I have already told you, fibroid is nothing but a benign condition of the uterus, where the myocytes of the uterus, the muscular muscles of the uterus will start proliferating at a higher rate, and it forms a small mass-like structure that is called fibroids, and the fibroids might be submucosal or intramural. Usually submucosal fibroid cause infertility, and a large intramural fibroid also is one of the reasons. And the fibroids, which are multiple in number, can cause infertility. Then we have got uterine anomalies like bicarbonate uterus, septate uterus, and also absent uterus. In one of the conditions, the uterus might be absent. That is mainly because of the developmental anomaly called as Mayer-Rokitansky syndrome, where the uterus is absent but the ovaries are present. Then Asherman syndrome. Asherman syndrome is nothing but extensive adhesions within the uterine cavity. One of the commonest causes of Asherman syndrome is tubercular endometrium. It can be also seen post-abortal as a post-abortal sequelae. Then coming to the cervical factors, the mucus might be thick. During the ovulation time, the cervical mucus should be thin, slimy, and it has to be stretchable. So the thick cervical mucus can cause a plug-like into the cervical canal, making the ascent of the sperms difficult. Then cervical antibodies can be there, and also infections. Then other systemic conditions can cause fertility issues. So tubal disorders like blocked fallopian tubes. Uh, Now coming to the disorders of the endocrine system. So disorders of the endocrine system can lead to imbalances in the reproductive hormones. We know there are different reproductive hormones which plays a crucial role in fertility. So I will come to it later. So what are the few reproductive endocrine problems which can lead to infertility? Thyroid disorders, hypoprolactinemia, etc. And also hypopituitarism. Hypopituitarism can be caused because of any cancers or space occupying lesion in the pituitary. Then we have got radiation and surgeries like radiation to the brain and surgeries, intracranial surgeries, chemotherapy. Also, these things can affect the pituitary and hypothalamus and pituitary itself. Now, this is the hypothalamo-pituitary ovarian axis. This is simplified one for the general public. So now we have got the hypothalamus here. So this hypothalamus is situated in the cranial cavity, brain, and it's a small structure there. Okay. So we have got arcuate nucleus here. So that will be secreting GnRH, that is gonadotropin releasing hormone. So once GnRH is secreted, GnRH is secreted and that acts on the pituitary gland. So pituitary gland will secrete FSH and LH. FSH is follicular stimulating hormone, LH is luteinizing hormone. So this will act on the ovaries. Okay. The first half is actually the FSH acts on the first half of the cycle. That is first 14 days the FSH acts, then the next 14 days the LH. And in between there will be overlapping of both the actions of both the hormones. So FSH is required for the growth of the follicles, whereas LH is required for the continuation of LH will rescue the corpus luteum, and corpus luteum will produce estrogen and progesterone, and these are helpful for the maintenance of the pregnancy. The estrogen will help in the growth of the endometrium, progesterone will help in the maintenance of the pregnancy. Estrogen is secreted in the first half and progesterone in the second half, predominantly. Of course, both are, estrogen is secreted even in the second half, but predominantly estrogen is secreted in the first half of a cycle, menstrual cycle. Now, this is about the female factors. So, I have told you in short about how the female endocrine system controls over the fertility and what are the various factors which can cause infertility from ovaries, tubes, endometrium and cervix. Now coming to the male factor. See, it is even the male partner also is equally important. Most of the people, what they think is the infertility lies in the female. It is a wrong conception. So, as already I have mentioned, the infertility can be because of females in 30% of the case, because of the male factor in 30% of the case, and in both in 30%. Both might be having problem. So, coming to the male reproductive system, So we know in male reproductive system what we think is only about the sperms. In female reproductive system, we can't just stick to the ovaries, isn't it? Because everything, tubes and uterus, everything comes into picture. So in male reproductive system, it can be problems in the ejection of the semen. It might be an absent or a low levels of sperms. It might be an abnormal shape of the sperm, or the motility of the sperm may be less. This is just to make you understand the male reproductive system. Here we have the testis. Okay, in the testis, the sperms are produced. The sperms again it is produced under the action of hormones, same LH, FSH. Okay, and these hormones will act on the testis. With the help of testosterone, which is produced locally, and the testosterone, these hormones together will help in spermiogenesis or spermatogenesis, that is the production of the sperms. These sperms are stored in the epididymis, and here even maturation will take place, and after that it goes through this vas deferens. This is a vas deferens. Okay, so this is a vas deferens. From here, it is joined by this vas deferens will open into the ejaculatory duct and the seminal vesicles. The seminal vesicles, which are a pair of glands, small glands, so they will be secreting the nourishing fluid to the sperms. So that will add to the volume of the semen. And from here, they open into the urethra. This is the urethra. And same time, here we have got the prostate gland. So prostate will be secreting, prostatic secretions are also very important because they keep the semen alkaline. Then there are some different other glands also, like bulbourethral gland, which will contribute to the lubrication of the tract. So this is a urethra, and then this is the end organ, the penis, and there can be problems even in the penis, like the erectile dysfunction. Then, if the opening is not at the right tip of the penis, the opening can be underside of the penis, like hypospadiasis, epispadiasis, etc. So this is in brief about the male reproductive system, how it is important. There can be obstacles in any site, like testis. There may not be proper production of the sperms. There may be production of sperm. There might be a lot of infection, testicular orchitis, etc. There can be epididymitis. Then there can be absent of this tube. This is called the vas deferens. So it might be absent in some of the genetic problems. There may be absent vas deferens, or it might be blocked vas deferens. And there can be an ejaculatory dysfunction itself, or there can be a block in the ejaculatory duct. There can be problems in prostatic secretion, where the semen will not be alkalinized, and so the sperm might have difficulty in viability. So I have already told you, in male reproductive system, it can be because of problems in the ejection of the semen. Ejection means if there is an erectile dysfunction. Sometimes may not be any erectile dysfunction, but there may be an ejaculation where there is no ejaculate at all. So it might be an absence or a loss. Sometimes ejaculate will be there. That is, the seminal vesicles are functioning normally, but there are no sperms. That is called as azoospermia. Sometimes there might be abnormal shape of the sperms, like a large head, globus head, etc. The movement might be very poor, motility may be very poor. There may be lot of dead sperms. So these are few of the causes of male infertility. Now we know by this topic, we know what are the requirements for conception. So requirements for conception is production of a healthy egg by the female partner and a healthy sperm by a male partner. So both has to be healthy, egg as well as sperm. And the tube should be normal, which will allow the uptake of the egg, and the sperm should be able to enter the tube where the fertilization takes place. Once the sperm and the egg comes in close contact in the fallopian tube, then the sperm should be able to penetrate the egg and fertilize. So it is a competition in between millions of sperm, and one sperm will be able to penetrate the egg. Once it penetrates the egg, the embryo which is formed in the tube has to be propelled into the uterine cavity. Otherwise, if it is not propelled from into the uterine cavity by the tubal cilia, it can get implanted in the tube. So, an implantation in the tube is called as ectopic pregnancy. Then, of course, finally, the uterus has to accept the embryo, nourish the embryo, finally leading to a healthy pregnancy. Now, what is this care encompass? So, but fertility care encompasses the prevention, diagnosis, and treatment. Everything is important. Equal and equitable access to fertility care remains a challenge in most countries, particularly in the low and the middle income countries. And fertility care is rarely prioritized in the National Universal Health Coverage Benefit packages. Though it is a real problem, it is not addressed properly. So, it is left uncared in many of the countries, in many of the communities, by many of the people. So, four basic goals. First is to identify and to correct specific cause of infertility. Infertility can be due to many causes, I have told you. We should be able to identify the actual cause of infertility. We should be able to provide accurate information to the couples. Then, of course, emotional support during treatment is required. See, infertility treatment can take a long time. So, a lot of patience is required. Few of the couples will come to me and immediately next cycle they want to conceive. But that may happen or may not happen. It might take some time. So, patience is important. During that period, they need a lot of emotional support because there are many people asking them what is the outcome, whether they were able to conceive. And finally, these couples will drop out thinking that they won't be able to conceive even with the treatment. But that is not the fact. You have to stick to the treatment, and every treatment goes on a stepwise manner. Then, of course, to guide about alternative treatment options in ART. See, artificial reproductive technique, there are many treatment options are there. I'll be telling you. Now, what are the basic investigation? In ladies, we will do a hormonal profile. There are so many hormones are there. So, most important hormones are FSH, LH, estrogen, progesterone, TSH, and prolactin. And in special cases, we may have to do total testosterone and DHEAS, etc. Then AMH and HbA1c. AMH is nothing but in a elderly lady, she may have the reserve might be compromised. That is, I have told you each one is born with a definite number of eggs. So the egg number might reduce. Okay. Uh, I hope you people are able to hear me. Okay, sorry for the technical glitch. There was power failure. That's a problem. So coming to the investigations in female, so we have got a gamut of spectrum of hormonal profile. Then AMH is just to know the reserve. Then HbA1c. You must be wondering what is this HbA1c? It's nothing but sugar test. Like in this past 3 months, how was your basic sugar level, which is very important. We do if the patient by mistake, like if she is a pre-gestational diabetic, so that is a very high risk for pregnancy. We need to control the sugar, so that's why we do a HbA1c. Then ultrasound can be 2D, two-dimensional, or 3D. 3D you get a good picture. 3D is usually done when you are suspecting some lesions in the endometrium, or if there's any anomalies in the uterus, like a bicornuate uterus or a septate uterus. Then we have got hysterosalpingography, sonosalpingography, MRI. Hysterosalpingography is the more cost-effective one to know the patency of the tube, to see whether both the tubes are normal, whether the uterine cavity is normal. Then if we see any lesions in the uterus, like a submucosal fibroid, we can also do a sonosalpingography, where we will inject the saline into the uterine cavity, and the intrauterine lesions will stand prominent at the back, with the background of the fluid. Hysteroscopy is like, we are illuminating the uterine cavity and seeing for the endometrial cavity, how it is, endometrium, or whether there is any adhesions within the uterine cavity, whether there is any scarring, whether there is any fibrosis, and also we see the os, the tubal os, whether it is normal or not. Laparoscopy to see the external contour of the uterus as well as the tubes and the ovaries. With laparoscopy, we can see the whether the tubes are patent by injecting the dye through the cervix, which will come out through the tubes into the peritoneal cavity. Then we have got endometrial biopsy. Endometrial biopsy is done to know the what phase is the endometrium, like whether it is synchronous with the hormonal changes in the uterus, whether there is any effect of hyper estrogenism, and also to see if there is any endometritis. Endometritis can be due to some bacterial infection, or it can be tuberculosis also, tubercular endometrium also, where we do a PCR testing. Now, male factor. What is the investigations we do in a male partner? We do semen analysis. Then, if the semen parameters are not good, like if the count is less than 15 million, then we call it as oligospermia. It might be mild, moderate, severe. So, accordingly, we will ask for DNA fragmentation index. Then, scrotal Doppler can be done if we are suspecting any varicoses. Then, of course, hormonal profile. If there is any problem in the sperm production, like hormones like FSH, LH, again estrogen, testosterone, TSH, and also we need to see their thyroid level as well as blood sugars. Now, coming to various treatment modalities, there are so many treatment modalities. It is not like you consult an infertility specialist. The infertility specialist will not directly ask you to go for a higher treatment. So do not be worried about that. First of all, we as a fertility specialist, we will be seeing what is the actual cause, what is the actual problem in you. We will, as I already mentioned, we will sort out the accurate problem and then treat it. So the treatments are like, we have got a simple one, timed intercourse. For that matter, if the patient, sometimes what happens is the patient may not have a normal menstrual cycle. Her menstrual cycle may be irregular, so she may not be able to keep in track of her fertility period, which is the fertile period. So we can help her by doing a serial ultrasound and seeing how the endometrium is and how the eggs are developing. And when she is about to develop the ovulate, we can ask her to have intercourse. So it is called as timed intercourse. Then ovulation induction is there. Ovulation induction is when, especially if she is not ovulating at all, then we give medicines which are very, simple medicines, and we see that she is ovulating, and accordingly we will ask her to have a timed intercourse. Next comes the intrauterine insemination. In intrauterine insemination, what we do is we will take the sample of the male partner, then we will process it, and the live motile sperms will be and free from all the white blood cells, etc., will be uh, inseminated into the uterine cavity. This is called as intrauterine insemination. The success rate is around 10 to 14% with intrauterine insemination. We usually do for 4 cycles. The cumulative success rate should be maximum with the 4 cycles, or up to 6 cycles if the partner desires so. Next comes the in vitro fertilization with the intracytoplasmic sperm insemination. Here, what we do is we will give the female partner injections to develop the eggs. The injections are nothing but the hormones. The hormones uh, are given in a higher quantity than it is normally present in the body. In the body, the hormones what is present, like FSH, is enough only to develop one egg. But if you are going for an IVF, IVF is slightly at the higher end of the treatment. So we need more number of eggs to be retrieved. Otherwise, it won't be very cost effective. So we try to give injections at a higher dose. It is not harmful to the patients, and then we will develop the eggs. After we get the eggs of sufficient dimension, like mature eggs, then we will collect the eggs through ultrasound, that is transvaginal ultrasound. A needle is passed, and we will collect it, and this procedure can be done under general anesthesia. It can be done under local anesthesia also. And once we collect this eggs, we will see the egg under the microscope, and we will see whether it is matured or immature. Matured eggs, for each matured egg, we will inject one sperm. If it is immature, there are even procedures like IVM, in vitro maturation, even that can be done if it is an immature egg. And for mature egg, direct insemination we can do, that is called as IVF ICSI, or we can do conventional ICSI, conventional IVF. Conventional IVF means where we keep the egg with the sperms, and the sperm which are competent enough will gain entry. But fertilization may be little poor with the conventional IVF. That's why we usually go for IVF ICSI, which is more effective and more fertilization rate is higher. Then we have got pre-implantation genetic diagnosis, where the genetic screening, diagnosis, etc., where we see if the patient is having any genetic abnormalities, then we can try to sort out those embryos and discard it, and we can use only the embryos which are carrying normal genes and that embryo can be transferred to the patient, female partner. Then in some conditions, what happens is she's an elderly lady, like around 40 years, she may not have enough eggs of her own. And in some conditions, certain conditions, the lady might be young, but her ovarian reserve might be very less due to some autoimmune disorders, etc. In that case, also, she will not have egg of her own. So, for such patients, we can always take eggs from the gametes from the donor. Even the sperms can be taken from the donors for azoospermic patients. And these donor gametes are usually done in a very meticulous fashion, and all the procedures are done in a in a legal way. Then third party parenting, it is, not very much this one in use, used now. That especially when the lady has got some mitochondrial disorders. Then, of course, the last one is adoption, where we can advise the patient, like last chance, last resort, we can tell that they can go for adoption. So, these are the various modalities. So this is in short about male and female infertility. And if there's any question. I'll be glad to attend it. Okay, I have one question here. What are the signs of infertility in women? Okay, signs of infertility, as I already told Lalita, that infertility means not able to conceive within 1 year of unprotected intercourse, regular unprotected intercourse. It's not that intercourse once in a while and you term yourself or the patient terms herself as unable to conceive. So, sincere trial for 1 year and not able to conceive is called as infertility. So, the patients usually should seek a fertility specialist. Better to seek a fertility specialist than to go for other modalities, because it's more when you are going directly to a fertility specialist, the right advice is given. Sometimes what happens is you will go for some other treatment. Actually, the tubes might be blocked, but the fertility specialist will go ahead to see how the tubes are and give the right treatment. And in case if you if you are not if you do not consult the right person, the a long what to tell period of treatment may be given to you, and in the end, like maybe when you are approaching your menopause, the patient may be referred to the fertility specialist. That time what happens is even the egg count will be less. So it's really a challenging situation for the patient as well as for the doctor, because the egg count, the reserve, if it is less, if it is inadequate reserve, then we might ask to go for donor oocytes, and that will become more expensive. And as the age advance, even the fertility result also will be less. The younger the age, better is the result also with fertility treatments. So I think I've answered this question. Okay, infertility causes, it can be in male as well as female. So in the male, anything which will prevent this, like sperm production, or the sperm number might be less, the count might be less, the motility might be less. It might be an abnormal sperm, or there may not be a proper track for the sperms to come out. I mean, absence of vas difference, ejaculated duct obstruction, etc. And in females, the infertility cause can be in the ovaries, it can be in the tube, it can be in the uterus or the cervix. Okay, improve the chance of getting pregnant. See, one is a sincere try. Another one is then one more, like the diet is very important. The lifestyle modification. Some patient might be overweight, or they may not be eating properly. They might be having a lot of junk food. They may not be doing any exercise. They may be living in living in a stressful condition. So lifestyle modification, then reduction in the weight is important to get a better result. And if there's any specific cause for infertility, that has to be detected and treated. Right age to get pregnant, of course. See, what I think by 30 years. But now the thing is, people are so much career oriented. They usually delay the pregnancy up to 35 years. What I would suggest is best age is 23 to 30 years. The aging in Indians is a bit, we are ahead of our Western counterpart when it comes to ovarian aging. Our ovaries become old before our face becomes old. That I should say. The thing is, if in Western countries, if the lady is 35 years, her ovarian aging also is 35 years only. That means she might have enough eggs. But in Indian scenario, what happens is we are 40 years, though we are 35 years by number, but our ovarian aging will be 40 years. That means reduced egg count will be there in the ovaries. So, any more questions? Yeah. So, once again, I want to tell I am Dr. Pramodha, working for Oasis Fertility, Mangaluru. It is in AG Hospital. So, you can call this helpline. You can come anytime. Always remember, it is best to seek the fertility specialist, especially if you are not able to conceive within 1 year of trial, and if the lady is above 35 years, she can try for 6 months, and then immediately consult the fertility specialist. And in case before marriage, if you were diagnosed with some problem like endometriosis, whatever, not to shy away. It is better as soon as the moment you get married or find a partner to start a family, it is better you consult the doctor instead of simply trying and wasting the time. Remember, time is very, very important, especially for the ladies. Thank you.